I very much accept that this should be the way the mock test should be conducted, because it is as we discussed a perfect Bruce protocol. Toughness and easiness are well coordinated, whereas the kind of mock tests that we conduct are on extremes of schizophrenia. Either they are too tough or they are too easy, but that's the reason I am having a retrospection. Maybe we should ask our top ranker students who join post graduation, while they are doing PG, they can better set the mock test papers, because as an examiner to set a paper, all the 52 weeks, we can't be a balanced personality, whereas that's the reason they go extreme either way. But I think that the performance in this test definitely is highly representative of the actual entrance performance. I really congratulate the good effort in composing the questions done by all our conglomerate of PG students. So let us go to the next question. The Hashimoto's thyroiditis. Hashimoto's thyroiditis will be giving rise to the papillary carcinoma. Carbuncle is fundamentally a Staphylococcus aureus infection. I am not sure what is the answer given for this question. Was it given B or A? A was given, okay. So A is the answer. Basal cell carcinoma is only locally invasive, it generally does not metastasize. In thyroidectomy, where do you basically apply the clamp in order to prevent the injury to the external laryngeal nerve? So if you do the nowadays everything is a keyhole surgery, laparoscopic thyroidectomy. So if you do laparoscopic thyroidectomy, you can directly visualize the external branch of the superior laryngeal nerve, which is very medial to the superior thyroid artery pedicle, and you will be ligating the superior pedicle as close as possible to the superior lobe of the gland in order to avoid an injury to the laryngeal nerve, is what need to be remembered. Saint's triad is gallstones, hiatus hernia, and diverticulosis. What is commonness for all the three? Individuals are fat, obese is a predisposing factor. In the tracheoesophageal fistula, the proximal end is blind, the distal end is communicating with the trachea. So this is the most common type of the tracheoesophageal fistula. What is Child's criteria, doctor? What do you have in modified Child's criteria? You have ascites, bilirubin, albumin and prothrombin time, and the presence or absence of encephalopathy is the deciding factor. Accordingly, you call it as grade A, B and C. If the child's classification scoring is between 5 to 6, it is called class A, 7 to 9 is called class B, 10 to 15 is called the class C, is what need to be remembered. Most gallstones are radiolucent and most renal stones are radio opaque. But as a house surgeon, what is the first gallstone you have ever seen? Unless it is radio opaque, where will you see on X-ray? So maybe exceptionally you must have seen the first radio opaque gallstone in your housemanship. Only that remains in our mind. So while in entrance also we apply the same logic and go wrong, is it not? So that's the reason. Anyway, I will show you once more a typical gallstone. What is a typical gallstone? Which is radio opaque instead of being lucent. So you can see here the opaque gallstone. Now what causes opaque gallstones, doctor? It is not cholesterol gallstone. It is a hemoglobin degraded, bilirubin excess conditions will be there, no? Pigment gallstones in conditions like sickle cell anemia, etc. So the pigment gallstones will be radio opaque in nature, is what you need to basically remember. Now what is radical dissection, modified radical dissection, extended radical dissection? So many terminology in the neck surgery. So you must be very sure on the classification of the neck dissection. When we say radical neck dissection, we will be removing all the lymph nodes in the zone 1 to 5. In the neck area, all the lymph nodes are divided into 1 to 5 zones of lymph nodes. All of them will remove. In addition, we also remove 3 structures: the spinal axis renal, the sternocleidomastoid and the internal jugular vein. Then what is modified radical neck dissection? We don't remove them, these 3 structures. So we will be retaining the SAN, IGV and SCM, that is the sternocleidomastoid. Still removing the 1 to 5 zone lymph nodes is basically called the modified radical neck dissection. Of course, if your stars are not good, examiner can ask you what is difference between type 2 versus type 3 versus type 1 modified radical neck dissection. I only leave it as a literature review for the future surgeon sitting here. Now let's go to the next question. Duodenal ulcer, it is the gastroduodenal artery which is the most common source of bleeding, and gastroduodenal is a branch of the common hepatic artery, and it will be giving rise to the right gastroepiploic and the superior pancreatico-duodenal artery, as all of you know very well. Now in ankylosing spondylitis, you know amyloidosis can occur, pulmonary fibrosis can occur. Does prostatitis occur? Very much. Prostatitis is one of the manifestations, extra articular manifestations of ankylosing spondylitis. What are you able to see in this radiograph, doctor? One of the manifestations of ankylosing spondylitis. The upper lobe fibrosis, pulmonary fibrosis, is what you are able to see in the case of ankylosing spondylitis. Pheochromocytoma can be associated with hyperparathyroidism, neurofibromatosis, medullary carcinoma, von Hippel-Lindau syndrome. Any of them can be associated features. Addison's disease. What happens in Addison? Do you find hypotension or a normotension? Low BP is what you see in Addison's disease. The low BP will lead to decreased renal perfusion, which will stimulate the renin-angiotensin system. Hence you have got a high renin levels in the case of the Addison's. What will high renin will do? High renin causes high aldosterone, which in turn will lead to the electrolyte disturbances. So you have, but even before that secondary hyperaldosteronism is stimulated by the Addison, what is the initial thing that will happen? You find hyponatremia with hyperkalemia rather than hypernatremia with hypokalemia. The hypernatremia comes into picture only when secondary hyperaldosteronism is stimulated. Until then still you have got a low sodium with a high potassium is a manifestation because of the mineralocorticoid activity which is deficient in the patients who are having the Addison's disease primarily is what need to be remembered. Then what is orlistat? Orlistat inhibits the pancreatic lipase, and that prevents the breakdown of the triglycerides in the intestine is what need to be remembered. It is generally used in obesity management. Now what is Atkins diet? How many agree with answer A or is it answer B? Huh? B is the correct answer, no problem. Actually what makes us fat? Is it eating ghee or eating potatoes? It is potato curry, potato chutney, potato sambar. So finally potato in buttermilk also. So finally you become a potato. So that is underlying cause what Atkins has discovered. So he said low carbohydrate, good protein, not the fat restriction, it is the carbohydrate restriction which is important as a part of the Atkins disease, Atkins diet. Now anti-mitochondrial antibodies are found in primary biliary cirrhosis, anti-LKM antibodies are found in autoimmune hepatitis, anti-RNP are found in mixed connective tissue disease. Like a parrot you must rattle out in the tomorrow's exam. Now where do you have micro and macrovesicular fatty changes? Basically we need to remember, doctor, that alcohol, diabetes, obesity, corticosteroids, they all lead to the development of macrovesicular steatosis, whereas the valproate, ketoprofen, acute fatty liver of pregnancy and Reye's syndrome are the remarkable underlying causes for the microvesicular fatty, fatty liver is what you need to emphatically remember. Channelopathies is one of the favorite topic of the examiner. This was my MD final year examination essay question. We never were prepared to face this question because you expect retinopathy or neuropathy, you can write pages. Channelopathy means unless you know you can't write. But still we have come out of exam writing 20 pages about channelopathies. So that is called the art of facing theory exam and getting a gold medal without knowing anything. We will give a short coaching on that also. So and that is very important, that's the reason, let me tell you, doctor, Is it true that the people who get more distinctions in undergraduation also get good ranks in entrance? Not always. If you conduct a correlation analysis, suddenly you will have in the last benches of the classroom getting best ranks. Because theory passing and theory exams are a different game from that of the guesswork, wild guesswork which you have to do in the entrance exam. So some people will be uncanny in their common sense, which is uncommonly available everywhere. Now let's go to the next question. But before that, please remember, sodium ATPase, potassium ATPase is a problem in some. Bartter syndrome, you have got various channelopathies. I leave this list to you in the explanatory notes, which you can anyway review before exam, at least a glance about it. One question will come. Now, paraneoplastic cerebellar degeneration, where do you have this? How do you recognize cerebellar degeneration? If you see the MRI, doctor, is there any simple way to recognize? Definitely. What is cerebellum made up of? Folia. Okay. Normally you don't see prominent folia if you take a MRI. Only unless the cerebellum got degenerated, then you find a prominence of foliae, foliar structure of cerebellum. I'll show you that this is how you can see the prominent foliar structure of the cerebellum, which is the hallmark of cerebellar degeneration. So cerebellar degeneration can be found in small cell carcinoma of the lung, ovarian carcinoma, breast cancer, Hodgkin's, in any of them it can be a paraneoplastic manifestation. Now chronic kidney disease, why do the people die? Chronic kidney disease can lead to development of atherosclerotic tendency. That is the underlying cause. Ischemic heart disease, in the hands of cardiologist, the prognosis become determined for a nephrology patient in the form of chronic kidney disease is what need to be remembered. Then after the ischemic heart disease, infections are the second most common cause which will succumb the patient of chronic kidney. Can you tell me which is the branch of super specialty very close to general medicine? Once more, nephrology. In nephrology you see infections, you see everything. So as a general medicine guy also you see a lot of things. Maybe you may forget what is the dosage of piperacillin and imipenem as a cardiologist, but you don't forget this as a nephrologist, because nephrology, infections, everything go hand in hand with each other is what need to be remembered. Now for the multiple myeloma you have a asymptomatic patient. Now tell me, doctor, what makes you to diagnose a symptomatic patient of multiple myeloma? How do you diagnose or suspect? Liver function test. If there is albumin globulin ratio reversal in liver function test, that is one of the important marker for possible multiple myeloma. But if he is asymptomatic, otherwise he has no bone pain, he has no high, any of the manifestations of multiple myeloma, how do you manage? Serial follow-up is considered to be the management of choice. Accordingly, the multiple myeloma asymptomatic patients are divided into the low risk group, high risk group based on the Bence-Jones proteinuria levels, M protein levels, whether the bone disease is there or not. Accordingly, they are being divided into high risk and low risk. So based on the risk profile, you should decide how serially I should follow up them. But finally, follow-up is the management of choice. In the case of a asymptomatic multiple myeloma patient is what need to be basically remembered. So rifampicin leads to interstitial nephritis, thrombocytopenia, hemolytic anemia, as all of you know. What is Kusumal sign, doctor? Normally whenever there is inspiration, what will happen? Negative intrathoracic pressure. That will increase the venous return to the heart and the jugular veins will collapse because the veins will drain into the heart. But if the cardiac tamponade or restrictive cardiomyopathy or a constrictive pericarditis is there, what will happen? The veins, great veins cannot drain into the heart. So at the time of inspiration, where you are expecting jugular vein to collapse, instead of collapsing, if it continues to remain prominent, in a case of constrictive pericarditis, then you call it as Kusumal sign. So what are all the conditions where Kusumal sign is seen, doctor? Anything that is preventing the drainage of the great veins into the right heart lead to development of Kusumal sign. So classically you see it in constrictive pericarditis, restrictive cardiomyopathy, pericardial effusion, right heart failure, cardiac tamponade, cardiac tumors, tricuspid stenosis, any right heart restriction. But we need to remember that if you take the Kusumal sign, it is a more classical feature of constrictive pericarditis and less classical of cardiac tamponade. So it is more commonly seen with the constrictive pericarditis. So that's the reason I probably think we can say Kusumal sign is rarely seen in, but still seen in the case of the cardiac tamponade is what you need to fundamentally remember. You also have a Ewart sign, Beck's triad, etc. in cardiac tamponade. Everything you must be encyclopedic. I am very sure you are all now. Now let's go to the next question. Which glomerulonephritis is low complement, immune complex mediated? Which glomerulonephritis is normal complement levels? Let us be very sure. Lupus nephritis, mixed cryoglobulinemia, post-streptococcal glomerulonephritis and MPGN. Complement levels are typically low because they are immune complex mediated. Whereas the hemolytic uremic syndrome, TTP, IgA nephropathy, etc., Henox-Collins, etc., they are all the examples of a normal complementemia fundamentally. CD19, CD22, CD103. Without CD markers, there is no entrance exam. Well understood by our junior doctors. So let us understand that in hairy cell leukemias, the cell of origin is of B cell phenotype. So that is the reason you find a pan B cell antigens which include CD19, CD20, CD22 and CD79B, but not CD21, which is a marker of a late B cell marker. That will not be found. If it is found, it is unlikely to be hairy cell. Then similarly CD103, 11C, CD25 are usually found in hairy cell, but not CD5, CD10, CD23. Somehow you need to revise CD markers of each of the leukemias and lymphomas, which is going to be the topic of choice in the exam. So this is how you find a marked lymphocytosis in a patient, and lymphocytes have got a hairy projections in hairy cell leukemia. They will be tartrate resistant acid phosphatase staining positive. TRAP positive cells are what you find in the case of the hairy cell leukemia. And how does hairy cell leukemia clinically present, doctor? Massive splenomegaly will be there. And if you try to do the bone marrow, how will it be? There will be a dry tap. Classical in the case of the hairy cell leukemia is what you need to fundamentally understand. Now Takayasu's arteritis. Have you seen any case of Takayasu arteritis? Young female, absolutely otherwise very sweet. Only problem is hypertension. When you have checked the radial pulses, what do you find? Pulselessness will be found. That's the reason whether you are after finishing DM cardiology in your life, or whether you are a house surgeon or a third year MBBS student, not checking pulse will totally baffle us in our diagnosis. It doesn't take 1 second. It's a habit that we need to get to catch the pulse. Just like giving shake hand to your patient when he walks into the OPD, we are never taught. But that has a high impact. Similarly, calling by the name the patient, half the disease is, half the pain is resolved. If you call Ramarao Garu, please come down, there is a difference between, hey, come and sit. If you, unfortunately, that is the address, we pick up the wrong habits. But let me tell you, post-graduation is nothing but catching that etiquette of managing patients. Let me tell you, already you are A++ when it comes to knowledge, A++ when it comes to enthusiasm, A++ in competitiveness. It's only that fine tuning of addressing Ramarao Garu as Ramarao Garu is what you need to do, and learn in post-graduation. Post-graduation is nothing but a higher form of undergraduation only, let me tell you. And in undergraduation we eat a lot of unnecessary academic grass. At least in post-graduation you are very specific. Dermatology means only dermatology. You don't unnecessarily read gynecology as a dermatology PG. So, but it is the behavioral modification. So anyway, let us talk about Takayasu arteritis. Basically, there was a Chapman and Hill's classification of the Takayasu's arteritis. So what are the criteria in that? Type 1 is classic pulselessness type with brachiocephalic trunk, carotid and subclavian involving. Class 2 Takayasu is combination of type 1 and 3. 3 is basically thoracic and abdominal aorta distal to the arch of aorta involvement, and type 4 is dilated type that involves entire length of aorta and its major branches is basically called as the type 4 Takayasu arteritis is what need to be remembered. In anemia of chronic disease, what will happen? Any chronic inflammation lead to a rise of ferritin, which is acute phase reactant, right? So there's a reason a high ferritin, not a low ferritin, is what you see in anemia of chronic disease. Where do you find low ferritin, doctor? Iron deficiency anemia, as all of you know very well. Now pneumococcal vaccine is indicated in diabetes, sickle cell, renal failure. Is it not indicated in cystic fibrosis anyway, by any chance? There is nothing like it is not indicated. Anything that is going to be responsible for a future asplenic state or immunocompromised state with the loss of complement system is an indication for using a vaccine against the encapsulated organism like pneumococcus. As simple as that. I am not very sure whether cystic fibrosis we give or not, but anyway as a exclusion we consider option D. 30-year-old with a sweating, shivering, etc. with the pneumonia but with confusion, encephalopathy component. So this is an atypical pneumonia which is caused by the Legionella pneumophila, as all of you know very well. Then hemophilia A is factor 8, B is factor 9, parahemophilia is factor 5. I have never seen a case of parahemophilia till now except reading in the book. You must be quite sure about the various hemophilias. What is sick euthyroid syndrome, doctor? When we are having sickness, acute illness, there can be the abnormalities in the T3, T4, TSH levels without any clinically overt condition. So a decrease of total and free T3 levels with a normal T4 and TSH is what you basically call sick euthyroid state. Now in narcolepsy we use the modafinil, which is the wake promoting agent which is used for the excessive daytime somnolence, and for the narcolepsy we basically use the modafinil. Now scooping of the ST segment is the classical feature in the case of the digitalis effect on ECG. It is not an effect of digitalis toxicity as such. It is called as non-toxic digitalis effects which are generally seen in ECG. So of the patient who are regularly receiving digitalis. Which patients receive regular digitalis? Rheumatic fever, mitral stenosis with MR with AF. So for them lifelong we give digitalis 5/7, 5 days for 7 days. If you take their ECG you see this scooping effect on ST segment. Zidovudine can be combined with which agent? Lamivudine and zidovudine is a good combination, but zidovudine and stavudine or zalcitabine and lamivudine are considered to be antagonistic combinations is what need to be remembered. Now the peripheral neuropathy of uremia, does it improve with hemodialysis? Not always. It is not an effective treatment for that matter. But what type of uremic neuropathy do you come across? It is classically described as a distal sensorimotor polyneuropathy, otherwise called a dying back neuropathy is what you classically see. In the case of the uremic peripheral neuropathy is what need to be remembered. Trinucleotide repeats is what you see with Fragile X syndrome, Huntington's, myotonic dystrophy, X-linked spinobulbar muscular atrophy, SMAs, you have the trinucleotide repeats. What is the genetic phenomena you see in trinucleotide repeat disorders? Anticipation. As the generations pass down, number of trinucleotide repeat mistakes will increase, hence the disease severity will increase. Grandfather has a mild disease, grandson has a severe disease, great grandson has a more severe disease of Huntington's chorea, which is called the genetic anticipation, is a phenomena which you see in trinucleotide repeat disorders is what you need to basically remember. We use IV immunoglobulin in Kawasaki, graft versus host disease, multiple sclerosis, Guillain-Barré, etc., etc. Now hepatitis B is the underlying cause for which conditions? In polyarteritis nodosa, MPGN, cryoglobulinemia. Whereas hepatitis C is important in lichen planus patients and porphyria cutanea tarda. Hepatitis C is the one which is implicated. Now, where do you see nephrocalcinosis? Proximal or distal renal tubular acidosis? Classically, it is found in type 1 RTA, which is otherwise called distal RTA. Now, tell me, doctor, what is the problem in distal RTA? Why does it lead to nephrocalcinosis? What is the underlying cause for it? As all of you know that proximal RTA, why acidosis is there? Normally bicarbonate become reabsorbed in the proximal renal tubule. But bicarbonate is not properly reabsorbed in the proximal renal tubule. Correct? So that lead to bicarbonate. That is the problem in proximal RTA. Whereas normally what does distal RTA does? Distal renal tubule does? It will do the acidification of the renal tubular contents. But that acidification is not happening. H plus is not jumping from the blood into the tubular fluid. So H plus is remaining in the blood and that is leading to acidosis in distal RTA. So if you take a patient of distal RTA, there is a chronic acidosis which will make the bone to lose the calcium in order to buffer it, and that predisposes to nephrocalcinosis. Reason number 1. Reason number 2, why do you find nephrocalcinosis in distal RTA, doctor? There is a decreased calcium reabsorption in the renal tubule. So that is the reason the amount of calcium in the urine is increased and hypercalciuria is there, and high calcium in the urine predisposes to nephrocalcinosis. Reason number 2. Then what is reason number 3? The citrate ion normally is reabsorbed in the proximal renal tubule. But the proximal renal tubular reabsorption of the citrate is inadequate. So citrate remains in the tubular fluid and calcium is also there in tubular fluid. So calcium and citrate combine with each other and form the stone, nephrocalcinosis. So this hypocitraturia because of avid citrate reabsorption by the proximal tubule and hypercalciuria and high urinary pH, they all basically predispose to nephrocalcinosis, which is a feature of distal or proximal RTA. It is a feature of distal RTA, not proximal RTA is what need to be remembered. Now if you want to do lithotripsy, phosphate stones break easily, urate stones break easily, but cysteine stones are very resistant to the lithotripsy is what need to be remembered. Whenever you are drawing pedigree chart, how to represent a male, female, divorced, married, adopted child, normal child, etc. you must be very sure. So this is male, female, affected, parents and one child, and this is how you represent the twins, and this is how you represent adopted child, this is the death and this is the miscarriage or abortion, this is how the twins are represented. These are the divorced represented, separated represented, so many representations of pedigree. I think already you learnt it and forgotten it in first MBBS itself, right? So let's go to the next question. If the maternal SLE is there, then that predisposes to the complete congenital heart block in the baby. Parachute reflex is when the baby is suspended by his trunk, then he will basically make a parachute like movement, and throughout life we are ready to jump from a parachute any day. It remains throughout the life is what need to be remembered. Now what is the developmental milestones? That way Junior Doctors Association paper is a perfect entrance exam classical paper where you have representation of all the topics without any polarity towards some and partiality towards other topics, no biases, good. So let us talk about it. Waving bye-bye, your baby will say when 7 to 14 months old. Then by about 1 to 2 years, he will say where is ball, where are chippies, what is that, no doggy, more push, towards our future orator will be basically start talking. And by about 36 months, he will be dry in the night. And by 24 months he will be turning pages of the one book one at a time so that he is ready for the future PG entrance. Now let us talk about NADA's criteria in congenital heart disease. Once more, there is a small change which is required in the frame of this question. We should say systolic murmur grade 2. Unless we mention grade, systolic murmur is a part of NADAS criteria. So systolic murmur grade 3 or more, diastolic murmur, cyanosis and CCF, they are all major criteria, whereas systolic grade less than 3, abnormal S2, abnormal ECG, abnormal X-ray, abnormal BP, they are all the minor NADAS criteria. One more correction is what need to be remembered. The fore milk satisfies the baby's thirst and the hind milk in the breast will satisfy the baby's hunger. You must be very sure to advise the mother that she must see to that the hind milk also is being taken by the baby. Now let us talk about the definitions. Perinatal period is between 22 completed weeks, which is 154 days of gestation, until the end of the 7 completed days after the birth is called perinatal. Now is the except is there in the question frame about febrile convulsions? Good. So we need to remember that the children who are younger than 12 months, when they get their first simple febrile seizures, they have a 50% probability of having a second seizure. Whereas after 12 months, if they get their first febrile seizure, then the probability will be lesser, 30%. So the age at the onset of the first febrile seizure has a bearing on the chance of the recurrence in the future for the febrile seizure to recur is what need to be basically remembered. Now Downs is because of the non-disjunction of the maternal chromosome, it is not ready to go into the daughter cell, and that lead to development of the trisomy that we commonly come across. Rotavirus is notoriously implicated to be associated with the development of rotaviral vaccine with the development of intussusception. 12-year-old girl, abnormal movements, what are we talking about? Wilson's disease. So Wilson's is associated with the chromosome 13q, the 13th chromosome is associated. Hereditary spherocytosis, we have 4 important defects in the channels, rather receptors. Spectrin deficiency, combined spectrin and anchorin deficiency, band 3 deficiency and protein 4.2 defect. Any of them can lead to development of hereditary spherocytosis. Fabry's is also called as angiokeratoma corporis diffusam, is a X-linked inherited disorder involving alpha galactosidase in the lysosome, which is the underlying defect, which is not autosomal dominant, rather it is X-linked, is what need to be remembered. We have got the dsDNA, which is abnormal in SLE, and you must be sure on all the American Rheumatology Association criteria for SLE, like a parrot in the tomorrow's exam, you must be sure about. Where do you have oncocytes? We find it in salivary glands, thyroid, parathyroid, kidney, etc. So the oncocytes are a feature. There is a entity called thyroid oncocytic tumors where you have the presence of the oncocytes. Now the ovarian tumors, out of all, germ cell, epithelial tumors, it is the surface epithelium which is the most common site of origin. Now what are the complications of myocardial infarction? Within minutes to 3 days you have arrhythmias, etc. In 3 to 14 days the chance of rupture is there, and chronic heart failure, cardiac aneurysm is after weeks to months. That is the timetable and calendar for the MI complications. Myeloid leukemia can be associated with the Downs, Patau's, and also with the Klinefelter also can be associated. Even trisomy 10 can be associated with the AML is what you have to basically remember. ESR will markedly be rising in anemia, whereas it will be falling down in the case of polycythemia. The opposite situation to that of the anemia is what you should be sure about. Now carcinoembryonic antigen, not only in colon cancer, it is also found in breast cancer, bronchogenic carcinoma. It's a very non-specific marker. Then what bodies you find in vaccinia virus, smallpox, Guarneri bodies, Bollinger in foulpox, Negris in rabies, etc., etc. Now what is Forsman's antigen, doctor? It is what you find in the case of the pneumococcus. where it is a constituent of the cell wall and responsible for the pathogenicity of the pneumococcal organisms called Forstmann's antigen. Ascoli's thermoprecipitation test used in the anthrax is a classical example of a ring type of precipitation test in the case of the anthrax is what need to be remembered. Serum sickness is an immune complex hypersensitivity which is of the type 3 hypersensitivity. Now the plasma protein binding of the drugs, what is the influence of the affinity of the protein binding on the clearance of the drugs and the volume of distribution? Let us debate on this important issue. What are the 3 proteins which can be binding to the drugs, doctor, plasma proteins? You have albumin, acid glycoprotein and lipoproteins. So whenever the drug is having a highly protein bound nature, how will be the therapeutic index of the drug? It will be a low therapeutic index is what you come across if there is a high protein binding. Can you give me an example of one such drug which had a low therapeutic index because of its high protein binding affinity, which we use as an anticoagulant? Warfarin is a classical example. Why there is a low therapeutic index for the warfarin? Little warfarin is more, we will start bleeding. Little warfarin is less, we start coagulating. So administering warfarin lifelong, we read it as a small sentence in CMDT. But as a clinician, you must be quite sure INR must be regularly monitored, and any time the patient can land in bleeding diathesis if he does not properly regulate his warfarin intake. So now let us talk about it. There are certain drugs like warfarin that way. Now similarly, what is the relationship between the volume of distribution and the protein binding? We need to remember that if you take a drug like warfarin with a high plasma protein binding, that leads to a low volume of distribution. Similarly, what is the cause for a high volume of distribution for chloroquine? It is the high lipophilicity of it. Similarly, if you take theophylline, why once more it is very low? It is once more the hydrophilicity of the theophylline and ethanol makes them to have a lesser volume of distribution. So that way volume of distribution depends on the protein binding of the drug, affinity of the protein binding, and the hydro and lipophilicity of the drug also decides the volume of distribution. Now ifaluzumab, there are totally around 10 to 12 monoclonal antibodies on which one question definitely comes in exam. So you must be very sure that ifaluzumab is a recombinant monoclonal antibody against the CD11A, and it is used in fundamentally renal transplantation, and also in psoriasis we use it very commonly. And there are problems with monoclonal antibodies. They can lead to bacterial sepsis, etc., because they suppress your immune system. So that is the reason they lead to, like any other immunosuppressant, can lead to development of sepsis, etc. So what is dofetilide? Dofetilide is a class 3 antiarrhythmic drug which is used in order to restore the sinus rhythm in the patients who are having atrial fibrillation and atrial flutter is what need to be remembered. There was a big study done on the dofetilide, Danish investigation of arrhythmias and mortality study called Diamond study. At the end of the Diamond study, they finally decided that let us use this class 3 antiarrhythmic dofetilide to treat the atrial fibrillation, especially in patients who have LV dysfunction. In order to manage their atrial fibrillation, dofetilide is the one which is recommended. Etosiban is fundamentally a antagonist for the oxytocin and vasopressin, hence it can be used as a tocolytic, but nowadays it is only theoretically in textbook for MCQs, it is true, but we don't really use it clinically because of its adverse effect profile. Now centrally acting muscle relaxant, which among these is basically? The drugs like carciprodol, cyclobenzaprine, metaxalone and methocarbamol, they are all the centrally acting spasmolytic agents which are acting as centrally acting muscle relaxant. But how about dantrolene? Dantrolene is peripherally acting, directly on the muscle it will act. It will act to to prevent the excessive release of the calcium by the sarcoplasmic reticulum. But we need to also remember that dantrolene also have a central effect. It is not a pure peripheral alone, but anyway, for entrance we can accept, we need not worry about small anomalies written in the last page of the journals. So that's the reason still dantrolene holds as a good answer for this question. The gelatin is the lipoxygenase inhibitor, and leukotriene receptor antagonist will be the Jafir-Lucast, as all of you know. Now we don't use allopurinol in acute gout, rather we will be using non-steroidal anti-inflammatory drugs in the acute gout. Then Saheli centochromone, which is basically a selective estrogen receptor modulator, SERM it is called as. Spaghetti meatball appearance is what you see in pityriasis versicolor. Now whenever there is a stable plaque psoriasis, how do you basically manage this condition? Can you use steroids? If you use steroids in a stable plaque psoriasis, it can predispose to what complication, doctor? I think we have entered the domain of our president's specialization. President of Abjuda is which department? Dermatology. So generally lot of presidents are dermatologists for junior doctors. While we were postgraduates, we had one similar dermatologist. Is there any specific reason? Any epidemiological study conducted? What is the reason? Maybe dermatology gives them sufficient time to basically be a very good entrepreneurial president and a leader. Actually speaking, the so-called great doctors, and they practiced in the OP and then finally went inconspicuous doctors. What is the only difference, doctor? It is all the leadership qualities that makes you, because medicine practice is more of a public relationship. People know only two P's. What is that? P for a politician, P for a physician. We are the only two groups who are highly exposed to the public. So that's the reason how well we can manage the public is all about becoming a good physician as well as a good politician. So that's the reason anyway. I take the overture to talk about dermatology, though we have some of the best dermatology postgraduates here. So we need to remember that we use the drugs like topical drugs in order to manage. Puva photochemotherapy we use, and cyclosporine, ifalizumab, etanercept, infliximab, any of them we very much use in the management of the psoriasis is what need to be remembered.